Good morning to everyone and welcome to the fifth session of the third webinar series on clinical management by WHO. My name is Dr. Albert Domingo from WHO Philippines, moderating the session for today again. And we'd like to say a special bula, hello, bonjour to our brothers and sisters, our colleagues in the Pacific. We've been noticing that in addition to our colleagues in Asia, we've also been getting some registrations from those over in the Pacific Islands. We'd like to say hello to everyone. And thank you so much. My background is dedicated to you this morning, and also the bula shirt I'm wearing, having worked before in Solomon Islands. I'd like to say also hello and good morning to my colleagues from the from the regional office, Dr. Sophie Dennis and Dr. Gary Kuniyoshi. And today is a very special and fitting closure or cap to our third webinar series. For the past 4 days, we have been touching on clinical management, on oxygen therapy, on antimicrobials. We had a preview, or rather a snapshot of what's going on in Singapore at the systems level yesterday. And today, I do remember for the past two webinar series, there have been a lot of questions. What about the role of those in the community? What about the role of the general practitioner? Those who are actually, they say, at the front lines or the front of the front lines. So we are fortunate for this morning to have with us an expert speaker on the role of primary and community care in the COVID-19 response. I'd like to introduce to you Dr. Donald Lee. Dr. Donald Lee is a specialist in family medicine in private practice and proprietor of a family medical practice in Hong Kong. He is the president of the World Organization of National Colleges, Academies, and Academic Associations of General Practitioners or Family Physicians, also known as WONCA, or simply the World Organization of Family Doctors. Dr. Lee graduated with his first degree, a BA from Cornell University in the USA, followed by his second degree, an MBBS from the University of Hong Kong in 1975 and 1980 respectively. He is both a regular and honorary fellow of societies of medicine, family physicians, general practitioners, and public health practitioners in Hong Kong, Australia, and the United States. Dr. Lee is actively involved in medical organizations and councils in Hong Kong. He is the president of the Academy of Medicine of Hong Kong and censor of the HKCFP. He is an active member and advisor of many Hong Kong governmental and public health bodies. Throughout his career, Dr. Lee has been a leading expert and ardent advocate in promoting better primary care and family health in Hong Kong, in China, and internationally. He also dedicates much of his professional time to academia and teaching. He is a professor in several distinguished institutions and is a frequently invited speaker at numerous local and international scientific meetings. He has also been a visiting lecturer to many different areas in mainland China. Dr. Lee is also active in community work with a philanthropic organization that supports community projects, a church-led social service organization, and a leading independent think tank of the Hong Kong Special Administrative Region. He is also a member of the Community Care Fund of the Hong Kong government to alleviate poverty in Hong Kong. Clearly, we have the right person for the task at hand for this morning. Please note that any discussions and opinions are those of the speaker and do not necessarily reflect the official guidance of the World Health Organization. Having said that, we have now 320 attendees on Zoom. Dr. Lee in YouTube. I'm still waiting for the count, have not seen it yet, but I'm sure there's over around 30 or 40 and going up. So over to you, Dr. Lee, for your presentation.
Thank you for the kind introduction and the opportunity to share with everybody some thoughts about work in the community and the primary care level. So let me load my slides first. Right. So we'll start off by just saying, I think everybody is familiar, primary health care is an approach to maximize the health and well-being of populations and individuals with maximum equity, effectiveness, and efficiency. I think this has been stated in the Astana Declaration, and we all believe there is a role of primary healthcare workers in any disaster preparedness, response, and recovery. primary healthcare orientated health systems are likely to be more resilient. And this slide is actually from WHO, noted for universal health coverage. Actually, in the community level, most countries are including testing and care for the COVID-19. Now, today, mainly, I'm going to share some experience of the work done by primary healthcare workers and those in the community in China. If you, I think some of you will notice that there is a recent publication at the Lancet to share the experience of China, because basically COVID-19 is gradually being controlled. And China's response actually shows the importance of domestic research and public health capacity. Governments and their leaders respect science, understand its value, and act on it in a way that is best for society. But more importantly, the role of primary and community care in the response is illustrated by actions taken in China and in Hong Kong, which I come from, which I will share with all of you. So, in general, strong health systems are vital to protecting people's health from risks and emergencies. Local action is vital. Community engagement is the first line of defense in the battle against infectious diseases. Family doctors are actually both gatekeepers and health promoters by empowering the community to build a firewall against the deadly virus. And family doctors play a vital role as part of the primary healthcare team. Family doctors are a trusted member of community and the front line of health systems. So in the preparedness, family doctors can share in risk assessment, prevention, vaccinations, risk communications. And as you can see, we feel that we shouldn't separate public health workers and family doctors. Family doctors should be community orientated. In fact, we're talking about primary healthcare teams that we all work together when we face disaster response and preparedness. And also it's very important to work with NGOs, non-governmental organizations, for example, in the community. They complement government plans and training for sabotage and rescue and natural disasters. And I'm honored to chair such a disaster preparedness institute in Hong Kong called the HKJC DPRI. And in the past, we've done work with WHO and all that in response to disasters in the community level. So the role of primary care and family doctors in disaster preparedness. First of all, most important, as I mentioned, is the integration of primary care and public health, what we call community-orientated primary health care. Because medical expertise of doctors contributes to the development of public health plans and policies on disaster preparedness. And family doctors can enhance communications with patients, educate and train the general public with self-help skills. But government determination and entrustment is, of course, essential. So during the pandemic, in the response phase, actually, family doctors and primary health care workers help block the viral transmission by monitoring people at designated checkpoints. And it slowed the increase of cases by treating patients and providing medical surveillance in the community. Most of the knowledge and skills required for doctors in emergency response are an extension of their medical profession. The comprehensive training of the specialty of family medicine actually allows family doctors to serve in any aspect of the health system and adapt to where they are needed. The world has seen family doctors practicing at many different levels during this pandemic, from at the ambulatory care clinics to emergency rooms, even labor and delivery and intensive care settings. A few examples on this a bit later. So what I'm going to now introduce is some of the work done in China. In fact, I published in the BMJ Family Medicine and Healthcare, a community health journal only not so long ago, together with Professor Zhu of Shanghai on introducing some of the things that family doctors are doing in China. I think the uniqueness is really the engagement. Family doctors do more than just seeing patients or treating, and this is what we talk about, community care. So in curbing the spread of the pandemic, they work closely with public health officers and guard checkpoints and protect the community. They enhance the screening process, and they provide on-site management of patients, and they act as a gatekeeper. Pictured here is actually at the airport, where you have actually doctors working with officers at checkpoints so that they can even provide immediate care when necessary. And family doctors join defense teams, working together with local neighborhood committees and community police, taking care of close contacts on confirmed cases and commuters entering regions under surveillance. So basically guarding to make sure that those possibly infected will not spread it all over the community. And they issue health warnings and advice on legal obligations. They conduct daily health monitoring and provide psychological support. They provide advice to residents under quarantine or medical surveillance on how to disinfect their homes and properly process their domestic waste. Chinese government provides designated isolation facilities for people who cannot secure an accommodation during medical observation. And general practitioners or family doctor teams are deployed to help train staffs of these hostels, temporarily used as isolation facilities. They also conduct health monitoring for people under isolation, and also provide psychological counseling and monitor the implementation of disinfection measures. There are fever clinics in China, and they are manned by general practitioners, and these are sentinel surveillance points. It helps in contact tracing, and these centers, these fever clinics are set up according to scientific evidence and rules, having adopted a series of infection control measures and patient flow to minimize the risk of cross-infections. The centers not only provide the basic medical needs of patients, but also closely monitor any potential cases. But a lot of the general practitioners in China, for example, have been trained as specialists before they became general practitioners in working in the community. So they could also engage in treating critically ill at the center of the epidemic. They reach out from the community back to the hospital and to treat the critically ill patients. Many volunteer to join medical aid teams reaching out to centers of epidemics. And some teams engage in the management of even severe respiratory wards and hospitals. General practitioners can manage the patient's underlying diseases and the pneumonia caused by the novel virus at the same time. We talk about the comorbidities, especially in those who have chronic diseases. And also the general practitioners can also manage the patient's psychological problems. And the picture here shows that the general practitioners actually can even deal with respirators and machines. In the rural areas, of course, there's a strong role of general practitioners. They will be involved in visiting close contacts, in epidemiological investigations, checking body temperatures, disinfection, and also maintaining daily practice and reporting epidemic information with the public health officers. And likewise, they educate the public. There's providing the correct information, alleviating fear as such. So rural areas, there's a strong role actually of these primary healthcare team members, including the general practitioners. Continuity of care, maintaining essential services is another very important part by all practitioners. In China, there has been a big effort to strengthen its primary care, and the country has launched a new round of reform since 2009 to strengthen primary care and establish a family practice system. The State Council actually issued guidance on establishing a general practitioner system in 2011, and then further in 2016 on promotion of family medicine contracts. It aims to extend family practice contracts services to the entire population by 2020. So under this contract system, families sign contracts with general practitioners who offer one-on-one services for patients, providing basic medical care as well as health consultations. And this has proved actually to be shown its merit during the latest outbreak, because contracted general practitioners provide continuous care to patients recovered from the infections in their 14-day rehabilitation and home care period after discharge, besides taking care of them during the acute phase. They conduct health monitoring, visit them twice a day, and manage their chronic diseases and ease their anxiety. They also support the patient's families and neighbors. And from a gatekeeping role, they seek assistance from hospitals and health authorities only when needed for problems that cannot be managed in the community level. But the general practitioners or family doctors in China really reach out into the community. They assist chronically ill patients to overcome inconveniences and barriers for care in their daily lives by providing individual personalized services catered to their needs. During the epidemic, chronically ill patients have to endure many inconveniences in their daily lives, and general practitioners help them overcome many of these barriers by providing individual personalized services. For example, before, if only 1 month prescriptions were given, now they would issue 3 months instead, so the patient does not need to return frequently, but they will be closely monitored. And the communication system, WeChat, widely used in China, has been used for online prescription and medicines that can be delivered for some affected areas door to door. Extended prescription services are also available for patients receiving consultation at secondary and tertiary hospitals in order to reduce the number of follow-up consultations and minimize the risk of cross-infections at hospitals. General practitioners also provide outreaching home visit services to stable patients under the established home-based medical care in the community. During recovery rehabilitation, family doctors take care of the clinical and psychological well-being of patients and extend that to their families so the whole community can return to normal life as soon as practical, reducing exacerbation of chronic illnesses. I think one of the biggest challenges really is things like post-traumatic stress disorders and the psychological burden it poses on people who have been exposed to the virus. The other area, of course, is telemedicine, exploring new modes of care, both providing telemedicine consultation, but also online support. And the advantage, of course, is it overcomes distances to provide quality medical care to remote areas, alleviate the shortage of medical experts across the country, minimize gathering and physical contact. And then there's multiple portal access through emails, video conferences, mobile apps, websites, and telephone, etc. Also, interdepartmental and multidisciplinary care physicians, specialty nurses, and pharmacists are encouraged to volunteer for online consultation. So it's, again, a team approach where everybody is involved in a team to take care of those who need care. And likewise, even e-hospitals, setting up special consultation channels to screen out potential patients, mitigate the anxiety and panic amongst the public, providing online diagnosis and treatment services, and of course, telemonitoring to make sure that the patients are all right, for example, those in home stay. But also, there's a great use on online training for primary care doctors, those who may not have up-to-date knowledge of the new virus, new procedures. This can be provided online. So teleconferences and webinars, and then also web-based medical reporting and follow-up system is also quite important for epidemiological follow-up. So basically, you can see the left side shows all the courses, online training for doctors to upgrade themselves, upskill them. And then there are local webinars that deal with local problems. And then there are web-based monitoring and reporting systems so that from a public health point of view, we can monitor the spread or the emergence of viral infections. And then, of course, international teleconferences. Timely advice and support to the public is very important. Calming fears is as crucial as stopping the spread of virus. Family doctors actively participate in online medical care platforms. They provide psychological counseling by phone and internet. They produce videos on health tips and participate in interactive TV or online programs. Seen here are two Shanghai family medicine experts, some of you who may know Professor Su and all that, appearing so that to answer questions in popular television shows, mainly to provide the timely advice and support to the public. General practitioners also use instant messaging tools such as the WeChat, community broadcast, and electronic display boards to disseminate information and mobilize local residents and volunteers to disinfection actions. This is quite important as well, to clean up areas that are at risk of spreading infections. They also help promulgate public health messages, such as avoidance of visits and social gatherings, personal hygiene awareness, proper ways of using face masks, hand washing, and household ventilation. All this is really quite important to constantly remind the public of what is the best public health measure. Also, as coordinators of community networks working together with local neighborhoods, health screening networks are created, which is of great value in contact tracing and investigation of the source of infection. These networks, led by general practitioners, also contribute significantly in the data gathering, epidemiological investigation, and efforts in blocking the chain of transmission. So technology can provide solutions by aiding doctors in making better diagnosis at a distance and have proven valuable during this COVID-19 epidemic. Advances in technology can impact on quality and safety provision of online healthcare, providing solutions to present difficulties and challenges. But these can also create further legal, ethical, and social concerns. So we must be careful on the way forward in the development of telemedicine. Also, with we mentioned delivering the right messages in the community is very important. So we need to work closely with NGOs and partners. For example, HKC, JC, DPRI propagates a lot of important messages to the public, again, on sanitization, disinfection, use of PPE, and many questions that the public may have. But engaging the community is actually quite important. And this is editorial I wrote in the British Journal of General Practitioners about a month ago. And I talked about solidarity, defined as unity that produces or is based on community of interest. Whilst physicians were the primary clinicians in charge of COVID-19 patients, actually volunteers, including senior consultants and professors from other departments, joined the frontline workforce. Family, friends, and the public have been supportive too, with well-wish cards and also support letters. Philanthropists and non-government organizations would donate PPE. Colleagues from the private sector would volunteer to see patients in public hospitals to relieve those under pressure combating COVID-19. So this is really solidarity, everybody working together as a team supporting each other in areas of deficiency. And likewise, influence of culture, religion, and tradition. So what promotes prompt community response during COVID-19? Religion, for example, in the region, such as Confucianism in China, places a heavy emphasis on the importance of respect for rulers, families, and social harmony. In China, people generally accept what authority figures say and express agreement. Healthcare policies are much more easily accepted and carried out with few questions asked by the public. The public is also generally receptive to respected local key opinion leaders and medical practitioners. There was little opposition, for example, to city lockdown, physical isolation, use of personal protective equipment, promotion of personal hygiene, surveillance, and screening measures. At working levels, there's trust amongst key workers within the hospital system, from supporting staff to technicians, frontline health workers, and department and hospital chiefs, which is important in ensuring togetherness in our fight against COVID-19. So this is something that our Chinese doctors have produced, which I think represents what they feel are important roles in the primary healthcare team and also in the community. I'm not a doctor. I'm also a policeman. As I said, we help guard, borders and all that. I'm not just a doctor. I'm also a social worker. I'm also a dustman. I help clean out sanitization. I'm also a volunteer. I can deliver medicine to those who need. And most important, I'm a doctor's family. This is what family medicine is about, the closeness, the trust, that patients feel that you're part of the family and you're in it, and we will work together for better health. So to conclude, strong health systems, which are vital to protecting people's health from risks and emergencies. And community engagement is the first line of defense in the battle against infectious disease. Family doctors play a vital role as part of the primary healthcare team and practicing at many different levels during this pandemic, being the first in, last out. This is the theme of our World Family Doctor Day this year, meaning that we are first to deal with patients who may have contracted the virus, but will be the last one out because we have to take care of them continuously. And the family medicine contract system has shown its merits during the epidemic in China. Telemedicine and online health platforms have played an important role in providing services as well. A few recommendations: resource allocation, including budget for public government funded primary healthcare, needs to be separated from secondary and tertiary care funding in hospitals. Otherwise, even though primary healthcare should be at the front line, they will often be left marginal to decisions with focus on hospital plans only. The biggest success are not in deploying family doctors into hospitals to support intensive care specialists, internists, and surgeons. Response at the community level is more important than the hospital-centric system approach. The biggest and most universal successes come from investing in the front line with a well-resourced primary healthcare working with teams at the community level. The COVID-19 outbreak responses remind us that community health care still needs further and continued development in China and globally. Also, congruent conceptualization of primary health care through policy is needed, avoiding selective primary care. And what do we mean by that? Not individual projects, just focus at infection, for example, but overall holistic healthcare, preventive care. There needs to be capacity building of primary healthcare teams. Indicators measuring progress should not be selective, breaking silos and providing innovation in data and technology with data integration of health information exchanges between hospital, laboratories, practice, and the community is very important. Telemedicine, the global risk of the health and well-being of everyone, dictate that ethical codes of conduct and regulatory frameworks need to be constantly reviewed and updated not only to address online medical practitioners, but also other players that facilitate this possibly commercial activity. So to end, I want to just say that COVID-19 is a global threat to all of us. Stringent public health measures are essential in controlling this infection, but cultural beliefs, religion, values, and behavior may bring about subtle differences in the outcome and burden of this infection on us. The task now is to bring the best of who we are and what we do in a world that is more complex and more confused than any of us would like it to be. Thank you very much.
Thank you so much, Dr. Donald Lee, for that presentation. Lots of information as always, but definitely something new perhaps for this week, because as we mentioned in the start, by the way, we now have 482 participants and on Zoom and another 62 on YouTube. And to those who just joined us or who weren't able to catch the opening, the whole week thus far has been about clinical management in the hospital setting. There was a brief respite yesterday when we discussed, when the Singaporean colleagues discussed what's going on outside in communities. But now we have an actual family medicine practitioner who can give us a preview of what's happening in the community itself. So with that, Dr. Lee, I'd like to invite everyone who would want to ask a question. If you are on Zoom, there is a button down there at the bottom of the app that says Q&A. You can click on it, you can type in your question, and it will show up on the screen that I, as the moderator, can see, and I can ask the questions on your behalf. For those of us who are on YouTube, there is a chat box that you can also use. I'm also monitoring it actively, and if I see a question that is related or pertinent, it will be asked from our distinguished speaker. So let's begin, Dr. Lee. So first question, the Raja Kumar movement would like to thank you for your passion in family medicine. My question is, family medicine is also giving mental health services to patients. However, some are already experiencing compassion fatigue on the side of the doctors, especially the young doctors. What advice can you give to young family doctors and general practitioners who are experiencing this? The term that our attendee uses is compassion fatigue. Dr. Lee.
Understand. I think not just young doctors, old doctors as well. It's something that, as I said, it's a challenge. So it's really, usually when we face these problems, it's understanding the situation, trying to negotiate a best solution for it, facing and then adapting. So it's really also part of work-life balance, but it's more than, it's not that easy. My advice is, no matter how busy we are, we should still take a little bit of time, for example, to do some exercise, and stay away from the news and all that. I mean, it's 24 hours. Nowadays, the media, everything is too sophisticated. So in a way, we're involved with news, with challenges, 24 hours of the day. And that really causes fatigue, mental fatigue as well. And it's something that may be beyond, ordinary person can cope with. So I would suggest that, first of all, physical activity is something limited, which may not be a good thing on the long term. So maybe some priority. It may not be easy to go out, because of social isolation and also probably gyms and all that. But I think exercise priority in giving yourself some time, spend an hour or so, even some stretching and all that, and turn off the television, turn off all your devices so that you don't get any further news on the COVID-19 for at least 1 hour or two. I think that would be good. And then refresh and also spend time with the family as well, talk to them about other things, what are they doing and all that. So it's really balancing out. During your time at work, obviously you will have to focus, pay your attention to all the problems, but maybe switch off really for a couple of hours each day. And then especially maybe before you go to sleep, I think that way you have a better night's sleep. Just some practical advice, I'm sorry we can't change what's happening in the world and the pressure will continue to come, but we try our best to balance. Hope that helps.
Thank you, Doctor. Definitely, we cannot change the world instantly, but let's find the balance in our work. Dr. Limuel Abrojenia is asking, as a family physician, I am grateful for the things you shared. That's from Dr. Abrojenia. During this quarantine, how do we effectively engage the family who lives in resource-limited settings? For example, those who do not have access to internet service.
Indeed, that will be really quite a challenge because we seem to rely on so. But home visits, it's not easy. But then that's something. For example, I showed the example. Okay, two examples from my presentation. One is dealing with the rural, the rural practitioner is really have to reach out. Some kind. Although we try not to gather, but I think with the proper kind of spacing and all that, I think human interaction is still important. I mean, we're lucky if we have the internet and all that so that we can have the physical distance. But then we don't still somehow, if properly spaced out, taking out the proper hygiene, this is still quite important. I think now and then, in places where there's no such resources, to have some gathering, because it's really alleviation of fear that people need, a interaction. So this is number one. And of course, information sheets. This is what we prepared even in Hong Kong, so that people who want something have a little manual on, what's the best way to do, what does distancing mean, how often should we be washing our hands, face mask, disinfection, and all that information. Maybe we can put it into a hard copy and distribute. But I would think that's still organization or information, sources. And then, of course, the other thing is I think most places would still have television or radio, even if the internet is not so popular. And so appearance, of family doctors on that. And these were examples that I gave in China that, in Shanghai, family doctors would appear on television shows, work with them on the popular ones, before a very popular movie, maybe, 5 minutes worth of, health education. I think we try to be innovative, and I do understand that it's a luxury. Not everybody everywhere we can enjoy, internet and we have all these resources. But let's try. But overall, I still think interaction is important, because if we're isolated, that really adds to the problem.
Thanks, Dr. Lee. So we really need that human touch, and we need to alleviate the fear of our patients, and not just call them patients, but also the people in the community. So there are three questions here. I'll first read those who are asking. So one is anonymous, and then the two others are Christian Poleno and Stefan Claveria. So their question, I'll just summarize, deals with this focus, this seeming focus in most countries on hospitals over the community. Of course, we don't want to see it as one versus the other, but a specific issue in the Philippines is it has come to a point where some concerns on surge capacity has led the government to pull out or to redeploy some community doctors in rural areas towards hospitals. The question I'd like to summarize on their behalf is there a way to balance this? Should it be towards one end or the other, or how do we go about it?
Well, I think understand manpower deficiency deployment, and then obviously it appears that hospitals are more sort of life-saving needs and all that really intense. So if you don't have enough manpower there, then you may not be able to save people in time. But then I think we need to look at precisely the message I gave at the beginning, that if we do it better, the preparedness and the response in the community, then maybe there'll be less need for hospitalization, early detection, surveillance, prevention and all that. So it's a balance, but definitely I think priorities need to be set in the sense that, yes, we deploy manpower to support hospital critical care and all that, but you must not take it all away from the community, because there's a strong role in the preparedness, prevention, and initial care, not to say surveillance and tracking and all that. So I think this is really up to the administrators, first of all, to realize the value of primary care in disaster preparedness and all that, and then so as to balance how much deployment. But as I said, general practitioners are equipped actually to help in hospitals, and I think we're all quite willing. But then some of us must be left to do the important role in prevention and early response.
Very good answer, Dr. Lee. I have a feeling that you will be quoted and that will be disseminated a lot over social media in the next few hours. I'm pretty sure. Now, there are two questions I'm seeing which are related, and I'll read those who ask. So Meredith Afwang and Rish Bumanglag are asking two related questions. The first question from Meredith is, community solidarity to be realized will depend much on the leadership, foremost of the local chief executive and its health officer. So the question here is, can you comment on how to best maximize the relationship between the chief executive and the health officer? To give context, Dr. Lee, here in the Philippines, the provinces and the cities are autonomous from the national government. So the local chief executive has almost independent control, and that's where the health officer reports. That's the first question. The second question from Rish relates to military-driven community quarantine strategies. What are your thoughts in engaging or working with the military? Is it good, bad, or again, is there a balance involved here? Over to you, Dr. Lee.
Okay, first question, really, I think with any leader or leader of a community, chief executive, all that, it's really the impression that willing to reach out right into the community, to really engage and talk to those who are suffering or have the need, rather than setting up policies and then delegating duties to subordinates. Go right down into the community, talk to people, listen to their problems, and then give them faith that under the leadership, things will happen, basically, or measures will be taken. I think that way, people feel that it's a team. It's not just one leader and then just soldiers underneath, but everybody's in it today. It's just like during a war, the general will go right to the front, in the battlefield. And all the soldiers will be very convinced that we're all acting together, right? Rather than somebody in a high tower, looking down at the poor soldiers forging ahead. So I think this really, the true engagement and really stepping into the community will be a very important, it's advocacy. It's also, this is how we generate this solidarity. So I think we see this, a lot of leaders understand this, so they will, even in protective gear, they will come down, and visit patients, and also, especially into areas of need. I think that will be convincing. The second about military, I think in a way, the image helps to show the determination and the importance of, for example, proper isolation and following the rules. I think a lot of people may, for example, even in Hong Kong, we've experienced that they don't listen to what we suggest in physical isolation, or those who are tagged as being contacts and all that will still go all over the place. So as far as the military involved is, I think it's an authority. I'm not saying that the military should go and put everybody in jail or whatever like that, but I think this shows the determination of government, that, and also the convincing of the public that this is serious. I think more important, together with just using the military, is to provide more public education. Why do we think that you have to follow these rules? Why you have to do this? Why you have to do that? I think and then with the authority of having a military behind will help. But I don't think that we should really go and put people in jail or just for breaking. Okay.
Thanks for that. So two questions. We now dive a bit into a little on the details of how it's going on, particularly in Hong Kong and China. So Camille Aguinaldo and Chitina de Ocampo Santiago have related questions. I'll read Camille's question first. Thank you for the presentation, Dr. Lee. I'd like to ask what you think the factors are that contributed to the efficiency of the community response, especially on the part of GPs. Is it because of an already strong healthcare system and community care, or is it the additional benefits and ensured security in terms of PPEs or others? And it's definitely an interplay of factors. But what, in your opinion, is the most important among them, if any? That's the first question. And the related question, Chitina is asking, how are family practitioners paid in China, per patient or salaried? How do you distribute patients among family practitioners? Dr. Lee.
Okay, the first question, it's really engagement. And also, as I said, integration of general practice and public health. This is how it works, or how it works better. You see the examples in China that the doctors will do a lot of work that other places feel that these are work of public health officers or other supporting team. They would actually man, for example, borders, at the airport, at train stations and all that. They would go to isolation camps to provide service. So again, this is policy directed. Okay, the willingness, first of all, is, as I said, culturalized. They feel that this is part of everybody's lives, so they should be doing it. Number two, I think recognition is very important, because you will have grateful patients and the grateful public acknowledging, the work that you've done. This is a big incentive for carrying on. And then, of course, government-wise, recognizing the importance of primary care, and then, allocating the work to the primary care rather than to hospital-based. As you can see, there's a lot that has been done in the community, for example, in China, that has allowed this. So again, I think top-down is quite important, that, and also the value, culture of the general population. As far as payment is concerned, the contract system, as I said, has proven to be quite effective, is that every patient that signs up with a doctor will get a small fee, all right? So the doctor, the more patients sign up with them, then the more income you get, although it's nominal. It's really a very small amount. We're talking about a few US dollars per person per year. But still, it's an incentive, it's a recognition, and it's also creating the doctor-patient relation. Moreover, this contract can be changed. So if your performance is not up to the satisfaction of the patient, they can change to somebody else. So you may lose your volume of patients that you generated. You keep them happy, then you can continue to enjoy this sort of added income. So I think it's a good incentive. And also, it's promoting what we always advocate, one family doctor per person. The continuity is really very important, because then you will really know your patient very well, and then avoid a lot of duplicate unnecessary investigations, over-treatment, etc.
Very wise words, Dr. Lee, and very well explained. So now there are two questions here. Let's shift back a bit to mental health. There are two anonymous questions, but I'm sure a lot of practitioners are asking. So first, this is not a question, but I would like to express my thanks. Thank you for the lecture, Dr. Lee. In relation to what the Raja Kumar movement said, it is difficult to keep our compassion during these trying times, and even more so, to maintain empathy, especially from all the input from social media. The bashing against healthcare workers can be quite drowning. Our healthcare workers need all the support they can get. They need all the love, because who else would battle the new invisible enemy than those who've been battling similar enemies throughout their life? Which brings me to the question from another participant. In this time that we rely mainly on technology, what advice or recommendations can you give to our doctors, nurses, midwives, all healthcare workers to prevent digital burnout?
Right. The first question, I think there's no answer, but it's a general impression. All right. What do we do? What drives us? It's basically our beliefs. That's why it's the culture, religion, and all that. But I think most healthcare worker is committed. We want to do something to help people who are in need, and also maintain their health. So first of all, it's the self-satisfaction, that you are able to carry out what you want to do. Second, of course, is also the recognition by others, gratefulness and all that. And I understand, the bashing and all that, but I think that's something that, one needs to sort out themselves. It's not what other people say, but you feel whether you've done something for them. I think that is more important, because there's bound to be, for example, there's 100 patients, 95 of them will be most grateful, but there will be 5 who would love to bash you, all right? So this is reality. So you think there's still 90 people who loves me. I think that's, will keep you going. But more importantly is you feel, I think, for us, for family doctors, we really want to provide holistic care. We want to have a very meaningful, trusted relation with patients. I'm sure you'll be able to do that. And I hope that with that, you will be much less burnt out. Telemedicine, as I said, it's a nice ecosystem, but then there's a lot of things really to be concerned, quality and safety, and also the overuse. As I said also earlier, you should switch off your phones for a few hours a day so that, it's not a continuous thing. But likewise, during telemedicine and all that, the length of time is actually quite important. I think you should expect to spend more time with a patient if you really do engage in that. And then it should be familiar patients. I would not suggest, a patient that you have never seen before to engage the first consultation through a teleconsultation. So there are many things, and Wonka is actually doing some work in this. We're doing accreditation on digital health. They are providers. We've done one pilot project on a big telemedicine provider in China. And that's what we look at, the safety, the quality, whether it's backup service, for example. If you detect something online, what are you going to do? Do you have the backup? So there are many things. But I think just basically tele-burnout, my advice is you need to switch that phone off, during a certain time of the day. Hope that helps.
That helps a lot. I mean, I can relate. Switch that phone off for a few hours, just to relax. All right. From the chat box, I'll read this because it's an exceptional question. But others, please use the Q&A button so that I can see it also in the question and answer panel. So Dr. Isidro Sia is asking, what could be a model from countries, perhaps other than China, which we've discussed already? So do you know of other models, Dr. Lee, country models that invest heavily on the preventive aspect of COVID response, public education, community empowerment? Because Dr. Sia believes that the home and community are the true front lines. What can we learn from these models?
Okay, I think all along, for example, WHO has advocated, disaster preparedness in the community. This has been done quite a few years already. It's been propagating, but actual prevention, it should be an ongoing thing, to the preparedness and prevention, because you never know when disaster or infection strikes. So to answer the question, as far as this time, nobody knew it's going to come. So, it's really, in a way, too late to take any preventive measures. But then we still focus on community response, okay? And I think most countries actually are doing this. For example, NHS, UK, definitely there's a lot of, they provide information and they do a lot of measures to prevent this. European countries, I think in Asia also, good examples is Malaysia has actually done quite a lot on this. Australia, with our former president Michael Kidd as the chief medical officer and all that, he has actually expressed a lot of measures that we've done. So I think most importantly is the concept that, it should be the primary healthcare level, mitigating in the community. That is the key point that, but I think most places in the world are adopting and realizing this. But, as there was an earlier question, is really the allocation of resources and deployment of manpower. That, I think, its subject is to availability of manpower. But the concept-wise, I think, is that we all agree that local action is still most important in the community.
Great. You mentioned, Dr. Lee, about local action, and maybe let's dive in a bit again into detail. I'm sure a lot will listen in now on the next question. Wilfreda Villanueva is asking, can you please kindly describe in detail what is being done in the fever clinic?
Right. Fever clinic, again, is isolation of those suspected cases, right? So it's for example, the fever clinics, there are a lot of guidelines as to possible contacts, duration, other associated symptoms and all that. But it's a way of possibly segregating those who may be infected into an area that is, I think there's much more precautions taken in these areas. For example, the fever clinics will have areas for taking samples, that is more safe for the provider. And also the fever clinics, that's why it's also important to be manned by family doctors, because they will be looking at comorbidities, existing problems as such. But most important, I think, with a detailed history of travel, for example, possible contact and all that, then, healthcare authorities can be alerted of those more likely to be infected, and then they can be under better surveillance. So number one is segregating those possibly infected so that they don't spread it around in other clinics. For example, if you don't have a separate fever clinic and it's in the same clinic as a general outpatient where patients with chronic illnesses also come, then in case there's one patient who's infected, then it will spread, to a high-risk patient. So this is segregating. And the second thing is to allow continuous contact tracing, basically of these high-risk groups. And then third is to have family doctors also provide care for other ailments on top of just fever.
Thanks, Dr. Lee. I just wanted to join a quick response from the Philippines. Actually, in Cebu, one of the provinces here in the middle of the Philippines, they're using what they call cluster clinics. So if there are practitioners here from Cebu, you might be interested that you do have a model of a fever clinic, and you call it a cluster clinic. So we can probably learn from that also in another venue. Now, related to the question on fever clinics, the time is 11:57, but there are still 463 attendees on Zoom and 76 on YouTube. So very expert answers, Dr. Lee. This one is still related to the referral pathway. So we were discussing about fever clinics. Now we have here, I think there's a family medicine colleague who is saying, I guess everyone would agree that family medicine doctors and general practitioners are the first line of defense in preventing the spread of COVID. With that, and here's the question, is it preferable to conduct a properly executed home isolation rather than bringing a COVID patient to a hospital? That's the question. And then Carmela Barcelona adds, at some point, a patient will be referred to a higher level of care and then back to primary care. So how is the referral system done in China to ensure, in Hong Kong, to ensure a seamless continuity of care? Dr. Lee, the healthcare pathway.
Right, okay, first home care, but you have to first examine what facilities are available or how many people are in the home, whether there are high-risk groups living there. But in theory, it's a good idea, especially in places where you have established family doctors. And that's why in China it works, because you have a contracted family doctor who can monitor you whilst you are at home care. Daily checking on your fever patterns and also even a little bit of telemedicine consultation and monitoring. So this is ideal, but then not everybody is so privileged to have a big home or a separate room, or some may be, a few beds in the same room. So that may not be the best, solution. And also what facilities, for example, with food, sanitization, and all that needs to be considered. But if such are available, I think it's an ideal solution rather than sending a patient to an isolation camp or hospital, that they stay at home, monitored by their family doctor. I think this would be quite ideal. As far as referring back, same thing. After rehab, after treatment of the acute illness, then back to home under close monitor. But again, the same criteria as I mentioned earlier is that, provided the home is adequate, and there are not other people that may become infected. I think that's, but otherwise, the principle is exactly, it should be community-based care if possible. And then even for those who are rehabilitating, to be done back in the community at their home.
Thanks, Dr. Lee. The time is 12 o'clock, but there are still two quite significant questions. Is it okay if we exceed a bit, Dr. Lee?
That's fine. That's fine.
Thank you. So an anonymous attendee is asking, how is contact tracing being done in Hong Kong and China? Contact tracing.
Well, once we've identified, in China, I think it's even more sophisticated, is that they have a code, they have a little bracelet that can track patients. And then there are different zones, infected zones, infected areas versus a safe area and all that. So those who have been infected will carry a bracelet so that they can be tracked, where they go. And then they will not be allowed to go to certain areas. So it's quite sophisticated, and it's the use of technology for that. This is still being developed in Hong Kong. So the way it works in Hong Kong is, again, we rely on the regular family doctors to be in close contact, and nurses actually as a part of the primary health care is very important, is that they will call patients every day to check on their fever pattern and have a look at that. But I think onwards, these bracelets actually are not that expensive from the IT point of view. And I think, it's a good way of allowing actually more interactions, because those who are safe can go to gatherings and then return in a more, normal life with the help of this kind of certification by a health bracelet.
Thanks, Dr. Lee. So there is another upsurge of questions, but I'll just trim down to some of the more pressing ones. So that was about contact tracing. And then this one by Pinky Galindez so Pinky is asking, what can you advise school administrators working with school physicians in the prevention of COVID-19? What about the school setting?
Yes, school is an area that we really need to be quite careful, because it is the crowdedness and also the possibility of cross-infection. But I think, first of all, the understanding of personal hygiene and the proper use of protective gear is number one. But if there are individuals that are infected, I think it's probably best to resort to online, teaching rather than the gathering. And this is the policy that has been adopted, in Hong Kong, for example, and China, is that I think most schools have adopted to using online, teaching for the past 5-6 months, rather than allowing the gathering, because it is indeed high risk. And COVID-19 is a new thing. We really don't know that much about it. Whatever we think, the modes of transmission and all that, we will find out by experience. So I think better be careful and vigilant rather than a little bit over-relaxed.
Thank you. Marlon Ko is asking, first he says, thank you for the excellent lecture, Dr. Lee. Do you allow primary healthcare physicians in the front line to practice traditional Chinese medicine? And what are practices like this?
Okay, in China, definitely traditional Chinese medicine is part of community care, all right? Every community health center in China actually has a TCM or traditional Chinese medicine segment, and they have proven to be very supportive, actually, in the management of COVID-19. There still needs, more scientific evidence as to the effectiveness of medication in the actual treatment. But supportive treatment, it has known for people who are down with high fevers and really are very uncomfortable. Traditional Chinese medicine has offered quite a lot of relief. And this is certainly part of the management in the community in China and heavily used.
Thanks. All right. Martha, I'm trying to squeeze in a few more questions, but they're really very good, Dr. Lee. So Dr. Martha Umali is asking, thank you very much, Dr. Lee and panelists. May we know the important role of family and primary care physicians in terminal and bereavement care during this pandemic?
Very good question. In fact, we have even guidelines. This is something that I didn't touch upon because, again, terminal care, bereavement is part of life. And this is an important role of family doctors because usually they have spent most of their life with the same doctor. So they understand their background, their beliefs, and all that. So they are really in the position to offer counseling and also suggestion of how handling. In fact, guidelines have been prepared, for this kind of terminal care and all that by our Hong Kong College of Family Physicians and a lot of NGOs have prepared. But to briefly answer, definitely a very strong role, I think, in terminal care, and also handling bereavement and also the associated psychological trauma.
Thanks. So I'll read just one comment and then the last question. Shoyosh said, "Good day. I am so happy and honored to have been given this opportunity to attend this session and to have heard Dr. Lee's vital points and learnings. You are truly a living advocate of strong family and community care. Thank you for being a beacon of not only the cure aspect, but also that we should provide care to each and every patient that we encounter." And finally, the last question, which I think is also fitting to be the last to be asked, Camille Aguinaldo is asking, will there be any difference in the community response for different waves of the pandemic, especially with Hong Kong seeing probably a second wave and hopefully not a third wave? Will there be a difference along the waves?
Well, I think so. I mean, with evolving of a third wave, it means that maybe we have not been vigilant enough in handling as far as surveillance, prevention, as such, and maybe we have not delivered the appropriate message. So the more so we need to do this to prevent another wave, the proper education of the public as far as vigilance, resilience, and proper personal hygiene, and all that. I think, we have a very strong role in this, number one. And secondly, alleviating fears, and also overcoming inconveniences. I think these are things that we need to manage. And so, again, the family doctor has a strong role in providing proper information and also encouraging, community solidarity, in a way, so that will help prevent another wave. And let's hope this never happens.
Thank you so much, Dr. Lee. And I just have to ask, because a lot are already messaging me, emailing me. Can we please have a copy of your slides and disseminate after this webinar?
Sure, most welcome.
Thank you so much. So with that, everyone who is listening in, there are 433 still on Zoom and around 70 plus on YouTube. Thank you so much, Dr. Lee, for being an expert speaker and for answering a lot of pertinent questions, not only for those at the front lines, but also those looking at the systemic concerns of this COVID response and the community engagement aspect. We'd like to remind everyone that at the end of each day, and this is the last day at least for this series, we do send out the links to recordings. You will see all of the recordings from Monday all the way to Friday and a shared folder with all the slides inside there. Plus, we'd also like to invite you in the future. So we'll be announcing when. As we know, this is an ongoing engagement. Should there be the next webinar series of WHO in the Western Pacific, we will let you know ASAP. Using your email addresses, don't worry, we'll reach out to you. I'd like to ask my colleagues, Dr. Sophie Dennis and Drs. Gary Kuniyoshi, for final words. Dr. Sophie.
Thank you very much, Dr. Domingo, and thank you, Dr. Lee, for an amazing presentation and giving us your expertise. Really just getting the feedback from the participants, they really appreciate it. So thank you for that. And just lastly, as this is our last session within this third webinar series, just a huge thanks to all the participants who have attended, who've shared the link and spread the information that we know is evolving all of the time, and please stay safe. Thank you.
Thank you, Dr. Sophie. Dr. Gary.
Yes, thank you, Dr. Lee. I learned a lot from this presentation. If I can use one of your phrases, I wanted to also thank all our frontliners that were joining us this past week. I also see them as first in, last out. I really like that that phrase that you use for your family doctors. And thank you, Dr. Domingo, for expert moderation during this past week. Thank you.
Thank you so much. And with that, we'd like to wish everyone, wherever you are in the world, a good afternoon, good morning, stay safe and be healthy. Thank you so much for your service to the frontliners. Goodbye.